Good morning, everyone. And it's a very good morning for me because I have the opportunity to speak to you about a topic I've been passionate about for the last 25 years, in which I understand is very important to the treatment cascade here in Canada. That's peer support. I'm going to talk about three main things. A research overview. I won't get into the details of the statistics in very great detail, but we'll talk about an overview of the literature on peer interventions. I'll talk about a specific example of a research project we conducted in Seattle. And then I'm going to end with some benefits and challenges to implementing and sustaining peer-based interventions. But I'm going to leave most of that for the true experts on the panel who have been doing this work for decades. I also have some notes from the field, some recommendations. I don't think we'll get to it. I have millions of slides and information, but I don't want to kill you with PowerPoint. So basically listen to me, tell the story. Those of you who like to multitask can also read along with the slides. But mainly I've prepared them all so that we can have them as a resource. And if anyone is interested or think they might be helpful for your work, I'll leave them with a conference and they can distribute them. Peer support. For as long as we have had health problems, we have had peers around to help individuals with them. It's truly a global tradition of non-professional, community-based peer workers with the idea that their practical knowledge, their shared culture really facilitates their efficacy in helping others. And the diversity of roles is reflected in a variety of terms: community health worker, buddy, promotor, accompagnator, advocate, lay worker, peers, and several policy statements now. And I understand a large part of the practice of HIV care in Canada also, if not requires, strongly encourages peers or peer advocates, treatment partners as part of care provision. When I started doing some research in peers, I really have been for 25 years, ever since graduate school, doing research in peer involvement. And I realized, looking back at the literature, there really wasn't a definition of peers. So we came up with one in our first work, and we said, really, there are four components to it. That first, peers share with the target group their key personal characteristics. We call this their peerness. Usually their demographics, or they share maybe a chronic disease state. Their contributions and benefits really derive from their status as peers. So that's really the strength in what they do. They don't have any particular professional training. In fact, it's most of them don't, and that's also what's seen as equating them more with the peers with whom they work. And then finally, they really work intentionally according to a protocol. It's not just operating in a normal, their social network. So there's the four characteristics I think of as peers. All right, what does the literature say about peer interventions? We know they're ubiquitous. Everybody seems to use peers, but there hasn't actually been a lot of really high-quality evaluation of whether or not they work. It's something we take for granted, but that researchers actually wanted to investigate. We started with a literature review of our own that we completed a couple of years ago. We did an extensive search of the literature bases looking for terms related to HIV, on all the articles through November 2010. So we looked for any article that has peers as the main basis of the intervention, and that was focused on HIV, because of course peer interventions are used in a slew of different health conditions. We found 518 studies, but only 117 met the criteria we were looking for. About a quarter were the most rigorous randomized control designs, the trials. Others were quasi-experimental, others cross-sectional, about half in the US and half outside of the US. In terms of the outcome, they were all related to HIV, but they focused on sexual risk behavior reduction, attitudes and cognitions about safer sex, like self-efficacy or knowledge of HIV, substance use, biological markers, CD4 count, viral loads, and other self-reported, non-self-reported outcomes. And there's some examples below. In terms of the format, most were formal meetings or structured groups, but others were outreach activities, more formal one-on-one, or the popular opinion leader interventions. And populations also varied widely. Many were school-based, youth-focused, on substance users, sex workers, men who have sex with men, people living with HIV or AIDS, other at-risk women, youth, and others like truck drivers, a lot of African countries. So what did we find after this big review? We found that basically peer interventions do seem to work, but there are a couple caveats. If you can look at this, and it's a little busy slide, but I'm going to draw your attention. Let me see where you can see it best. Over here. So what we did was look at just the number of studies. We used a very liberal estimate. So if the study looked at, say, sexual risk behavior as the outcome, if any one of their outcomes showed a positive effect, a statistically significant effect for that outcome, we considered that, that study as showing a benefit or showing a positive result for peers. So you can see just the first one, sexual risk behavior. Out of the 78 different studies, 60 showed some kind of positive result. So almost 77% of them showed that their peer intervention improved, usually over a control group or a baseline indication. So they were efficacious mostly for sexual risk behavior. You were able to change attitudes and cognitions, HIV knowledge, even substance use to a certain extent. However, when it came to the biological markers, only a third of them were efficacious. In the other self-report, these are things like, you guys are familiar with electronic data monitors, the MEMS caps, which you can take off and records every time someone takes a medication. So if they were looking, say, at adherence, it was a little harder to show that that was really efficacious. So really a range of interventions. This is really the meat of the slide, of the talk right now in terms of do peer interventions work. Here is the range that we saw. We also wanted to look, did it depend on how they studied it? Did they use really the gold standard in research, the randomized controlled trial, or did they use maybe a less rigorous research intervention? And we found that most of the domains didn't matter. Pretty much they stayed fairly consistent no matter how they were studied. The exception was the biological markers. So not only was it harder to show the effect of the biological marker, but if you used a more rigorous design, you were even less likely to show an effect. So the RCTs, only 1 out of the 8 showed effect. And why do I put this up here? Well, a lot of times when we're trying to get funding and trying to increase support for our interventions, it's important for some funding organizations that you show a really hard outcome, like a viral load you have to decrease or your CD4 count you have to improve. So it's nice to have research in the most rigorous trials that can show us these kind of hardcore outcomes that, for instance, the medical community really would like to see. So it's been difficult for us to show this. We also looked at moderators of outcome. This is to say, in which areas were the studies most effective or efficacious? We looked at study locations. Studies in the US tended to be more effective at changing attitudes and cognitions than studies in developing countries looking at these same outcomes. Studies that use outreach tended to be more effective at changing substance use than those without including outreach. And the population study also varied. Those looking with non-PLWHA and non-MSM were more effective. In other words, those two groups were harder to change behaviors. When you're actually focusing on people already living with the virus and MSM, it was more difficult to change their attitudes and cognitions and their sexual behaviors. So we concluded that findings suggest we can have some confidence in peer interventions, yet more data are needed to demonstrate an effect in the most rigorous study designs and with outcomes that are not potentially affected by respondent bias. In other words, not just self-report, some of the more really harder biological outcome measures. I want to look at a couple other reviews that have come out around that time. There was one review of 24 studies of youth using peer-led interventions. They found targeting specifically on youth. And the findings show that the majority had positive change in behavior. And here they just looked also at the number of studies. So there were 16 studies. You can see for knowledge, 10 out of the 16 showed a positive effect on knowledge. Abstinence, much lower. Recent sex, only 3 out of 16. Number of partners, 0. They were able to reduce. Condom use, self-efficacy, a little bit easier to change. Symptoms, much harder. So again, you have a similar pattern. People will tell you things that they feel better or things seem to be working or the behaviors seem to be changing, but when you look at some of the harder outcomes, it's difficult to show those effects. Another study, a more comprehensive study, was done about the same time we published ours, but it focused on work in developing countries, these resource-constrained countries. They found 30 peer review articles, and they did find significant effects. It was possible using peers to increase HIV knowledge, to decrease injection drug use equipment sharing, increase condom use. And they concluded, similar to ours, that meta-analyses indicate peer educations in developing countries are moderately effective at improving behavioral outcomes, but they showed no significant impact on biological outcomes. So again, the same finding. Another study looked at peer interventions for youth, found 17 publications. They had few that were really statistically significant. That was beyond the level of chance. Was there really a difference between people who got the intervention or not? And again, a similar conclusion, that there's no clear evidence. This was a little more pessimistic. There's no clear evidence of the effectiveness of peer education concerning HIV prevention, adolescent pregnancy, and sexual health outcomes for young people in the European Union. Again, they focused on the European Union. I meant to mention that. Okay, let me tell you a little bit about a specific study that we did in Seattle. This was an NIMH-funded study for 5 years. We had a pilot study in the Bronx before we did this, and our idea was to look at peers. We call them buddies for the purpose of this intervention. We compared it with a pager condition, but I'm going to focus mainly on the buddy intervention for this talk. We recruited people from primary care. I'm going to go through the slides a little bit quickly. Although my grandmother was from Nova Scotia, I spent many years in New York, so I do speak very quickly. You can raise your hand if it's too quickly, but I'll try to keep up with the slides. We got basically people starting or switching antiretrovirals, or those who were having difficulty in the clinic to be in this adherence trial. We used nurses to recruit the patients at the clinic, and we used a computer to assess their answers. We paid them for their time in the study and followed them over the course of 9 months. Our conceptual framework was basically that your adherence was our main focus on the HIV adherence. The more satisfaction they had with their support, mainly through their buddies, through self-efficacy about taking their medications, through lower depression because of their interaction with their buddies or peers, and because of greater knowledge about their regimen and HIV, would increase their adherence. Those were the main measures that we looked at. We used both a self-report adherence as well as, again, these electronic medication or drug monitors that looked at a more objective measure of the main outcome. In terms of the components, twice a month, so every other week, we had buddies meet in a group instead of so note it was not in a one-on-one intervention. It was in a group. They discussed adherence, they problem solved around life issues related to adherence, and there was a harm reduction approach according to substance use. And then there were weekly phone calls for more in-depth, more individualized, more confidential support. There's a chance to broach more sensitive issues, and it was better suited for some of the participants who had trouble coming to the clinic or concerned about confidentiality. Who were the buddies? We recruited people at the clinics who were mainly adherent to their own HIV regimen. They were willing to participate. They were socially skilled. They had to commit for 6 months, and either they themselves or the staff referred them. We had a peer training that was limited really to just 2 days, and then ongoing supervision, in which we talked about setting boundaries, how to accept help, strategies for adhering, some basic counseling strategies for HIV. And again, ongoing supervision is very important, as you know, in peer work, and so we followed them after every training intervention. I won't talk as much about the peer intervention. I'll tell you, we had a very high standard of care in this study. Everybody had to meet with a series of clinicians and professionals before they were even started on a HART regimen. So this was also an intervention in and of itself, actually. And the participants, I told you quickly, they were just in 4 arms. You either got a buddy and the pager system or just either one. There was a baseline session, 3-month and 6 and 9-month follow-ups, and the intervention was a 3-month protocol. So what were the results? Overall, I'll tell you, in terms of the participants, basically reflected the Seattle population. So we had about half Caucasian, 3/4 male. MSM is the major focus of the epidemic in Seattle. Overall adherence was fair. 67% had perfect adherence at the baseline. Like most intervention studies, you see it tends to go down over time. And in terms of demographic correlates, who were the ones who did better or worse on adherence? Those who were employed actually did better on adherence. We tend to find that. People who have a schedule, a more structured week tend to do better taking their medications. African Americans did less well. That's a consistent finding that we've found across other studies as well, but wasn't correlated with gender, income, education, other demographic factors. But did it work? Did this buddy intervention actually improve adherence? According to self-report, those who received the buddy support were more likely to not have missed any doses in the last month. And I'll show you a couple slides that show this, but basically, again, over time, adherence tends to drop, even in a research study. But at the point that we looked at the final intervention, those in the buddy condition tended to do better than people that weren't in the buddy condition. But over time, we could not sustain that effect. Another way you look at it is the difference between baseline and 3 months adherence. They all did a little bit worse, but the buddies stayed closer to their original. Those in the other condition tended to deteriorate more quickly. And this was true both from 3 to 6, 0 to 3 months, and then later on in the intervention. But by the end of the intervention, they were pretty much on track. So it's very difficult, even when you get positive results, to be able to sustain them. And in terms of the more objective EDM, that MEMS cap. There was a trend for it, but not statistically significant. So similar direction. At the end of the intervention, those without a buddy had higher adherence, but again, we could not sustain that during the course of the intervention. And again, another way to look at it, those with a buddy were doing a little bit better than those without, even according to the more objective measure. But again, by 6-9 months, pretty much if we don't keep up the intervention, we see some relapsing into poor medication. Biological markers, you've noticed the theme about this now, it's harder to show effect on biological markers. In terms of our a priori, what we had hypothesized at the beginning of the study, weren't able to find an effect. And we wondered how much were participants participating? Did it have to do with something related to that? Well, pager support people participated, but buddy support, there was a range. There were only 6 meetings during the course of the 3-month study, right? Because we met twice a month. And there was a range of meetings that people were able to attend. Maybe you've found some of this in your own work, that the attendance really tends to vary. I hope that's something we can talk about in the panel as well. The biological markers, we did do some exploratory analyses after in looking at the buddy participants and found that the more you attended the sessions, the better you tended to do, even in terms of your viral load at 3 and 6 months, even at 9 months. So typically people who are attending an intervention tend to be a little healthier anyway. But for us, it gave us some hope that the more you engage in an intervention, if we can get people to engage in intervention and make it something that they want to attend and want to come to, then we have a better chance of helping them in terms of their biological outcomes. So in conclusion then, medication adherence tended to start off high and then to erode over time. But we found the buddy and pager intervention did show some success, particularly for the self-report adherence outcomes, particularly at the 3-month time points. And CDC did recognize this as one of the few interventions that really have, quote, good evidence, and they're listed on their website, that both the pager and the peer support. And those can be found on their CDC Dissemination of Effective Behavioral Interventions website. All right, I want to switch gears a little bit. Like most of the research I showed, there's been a focus on, does peer support help the clients that the peers work with? What about the peers themselves? Those of you who are peers, who worked as peers, who supervise peers, who run peer programs, notice, I'm sure anecdotally, or just in terms of your observation, that the peers tend to do very well. They tend to actually improve over the course of the treatment, and we have found this to be true too. In the pilot study we did in the Bronx, I told you about, that preceded this Project PAL, we did a little qualitative study of 9 individuals who we had in the study. All of them were peers in the program. And we asked them after, thank you for doing your work, here's your reimbursement and your compensation, and we did a lot of assessment of the people that you worked with, but what about you yourself? What do you think was the impact of this intervention or working in this study for you? We noticed 4 main themes. The first one was a general, I'm not going to read all these quotes, but I'll tell you the themes. Social acceptance. Being with those who are going through the same thing. Almost all of them said that. That was helpful to them. Feeling accepted within an otherwise very isolating disease. And this was in New York City, keep in mind. One of the epicenters in the US epidemic. Feeling safe in the program. That was important. That was something that they found. Secondly, there was reciprocal support. And there's a therapy that Reisman wrote about, the helper therapy principles. How do you get the best therapy? You don't go for help, you give help. And in that, you have a reciprocal process, and that actually leads to your own improvement, your own growth. And they said there was support from peers, not just support they gave to peers, but support that they got from the peers themselves. And they received this on many different levels. And by helping someone, I got something in return. Every single one of them mentioned that. And helping people through their own example. A third theme was their own personal growth and empowerment, this sense of resilience. Feeling entitled enough to talk about the disease was important to them. They didn't feel that way in other situations. They felt that the training helped them to do that. Being part of Project Heart gave them strength. It gave them a change in outlook. I'm a totally different person now, one individual said. Finally, there were some challenges, particularly resistance in the other individuals. There were obstacles to accepting support that all of them accepted. Remember, this was based on a very brief training. People didn't go through a full master's program in social work to understand the resistance on the part of participants, to understand what it's like to be a helper and to not be able to help an individual. So they found that frustrating and difficult, that there's certain people they weren't able to reach, that didn't return their phone calls, that didn't come to the groups. Often they would take that personally. And then no control over loss. This was earlier in the epidemic. We did lose 2 individuals and 2 core buddies that were in the program during this time. It was very hard on the peers. In fact, one buddy dropped out and never came back after one of his colleagues passed away. And in conclusion, I'll talk a little bit about the benefits, some of the challenges of peer support. So to clients, can provide a specific type of support that can often be done, that comes from standing in the same shoes, being in the same boat. We can target, quote, hard to reach populations. You saw in one of the studies that outreach activities were most successful with substance users, and that's what's most difficult for institutional substance use treatment centers to do. You need the peers to get out and really reach out to communities. Good for those who fear stigma, because they often don't come in. They can take a harm reduction approach very easily. And there are some benefits, as we noted, on HIV outcomes in the literature that we saw. I was going to mention in terms of, I know the theme of this conference is about the cascade, and maybe this is something we can bring up in the panel discussion after, but thinking about where in the cascade are peers most helpful. And when I look at these potential benefits of peer support, it makes me think about earlier in the cascade, before people are even affected, actually. And once they are, helping them to get into testing and care. Those are particular times, I think, are really key points for peer support. And those weren't always the things that have been studied in the research, right? They looked at virological outcomes, immune suppression later on when people were in care. But what about before they're in care, before they know they're even at risk for HIV? So I think there's a conversation about where best to use peer resources. And then benefits to the peers themselves, as we talked about, through the helper therapy principle and their own empowerment. Negatives, there's downsides, the challenges of peer support. Peers overstepping, sometimes dispensing advice that they're maybe not qualified to give. It's certainly a big fear of the providers that we worked with. Harm to clients through their inexperience or lack of skills, boundary violations, what to do with peers that want to date you, and how do you handle that? What do you do when the study's over? They still want to be friends. Breaches of confidentiality, legal liability. I should say we really didn't, these were more than anything a lot of the fears that we had going into peer work. They're often there. I actually see them happen very infrequently. But they are fears and obstacles to actually setting up a peer program. And then to the peers themselves, the challenges, their own sensing their own personal failure. It actually isn't their failure, of course, but they feel it that way when they aren't able to reach the clients they're assigned to. Maybe compromising their own health because they're working so hard, and their own risk for relapse when working with people. Remember, we had a harm reduction approach, so it's difficult for some people to be around others who were still actively using. Recommendations are to broaden the opportunities for peers, to strengthen their training, though, and to really do some more research on what works. I think there's really this disconnect between those of us in the field who see peers, see how effective they seem to be, see even the effect on the peers, and then the researchers telling us, well, how come we can't show that effect as well in the research? Are we not studying it right? Are we not looking at the right things? Are we not talking to the right people? Are we not looking at the right outcomes? And it's important, not just because we geeks in science like to study that, but because that's how we get our funding, and that's how we can argue to roll out more peer programs. So I think that's an important aspect of this work that needs to be done, really more rigorously examining the peer activities. I know it's difficult from the community perspective. Very little of the funds are available for research. Sometimes it's a short evaluation component, and most folks would rather put that money in hiring another peer and going out and doing more work. But it's the really rigorous evaluations that are going to, in the end, lead to more resources to do the peer work. So then disseminating and sustaining successful programs, and how do we do that? I do have some notes from the fields, things I found helpful. I think I have a little time. Maybe I'll go through some of them quickly, but again, I'm not going to go through every slide. This is to give you a sense of what's available out there and some of the resources if you want access to them. And these are some really, we presented this, and there are some good resources that I've noted here on the slides. And again, I'll make them available to the conference if you think they might be helpful. But how do you select peers? That's kind of an important thing when you're starting out. We found the clinic that we started, the doctors would often select peers to us. And we found soon enough, those are the people that were having difficulties that they recommended to us. They heard there was a peer program. They thought they could be helpful. But we thought we wanted people that were able to help others. And we did find they don't have to be perfect adherers. In fact, it sometimes helped when you had someone who had a challenging start on antiretrovirals, but then actually, or a period of addiction, say, but then were in recovery, then had some improvement, and they were able to relate better to people still along that path. So selecting peers is actually key. How do you do that? How do you interview them? What questions do you ask? In terms of the training, you have very little time, right? Again, these peers aren't giving a master's program. You're not going to have them come for weeks and weeks. What can you do and how quickly can you teach them about this? But there are some things that we found are most helpful. But basically, we learned you have to do role plays and you have to practice the skills. And that no matter what you teach them at the beginning, you have to teach them again and again throughout the course of the program. It's just through active experiential learning that most of what they need to know is acquired. And a range of topics from communication skills, diversity, disclosure, defining and reinforcing the boundaries, all these things were important for them to learn. There are some resources from HRSA, there's a website here, this Family Health Network, that also give good examples of study programs. Different recruitment strategies, how do you find your peers once you know what you want to get? What are the key elements of what peers do in relationship? I didn't talk about some of the process research, but there is evaluations about that. If peers are successful, what is it that they do that is really successful? And how do you train them to do that? Is it that they build trusting relationships? Is it that they just provide education? Is it the mentoring? Is it their examples? Is it their peer navigation through the clinic? Do I have a couple? Yeah, is it their connection with the treatment team and how they kind of liaison from the community to that treatment? We're not sure exactly what's helpful. Is it helpful for different clients, for different outcomes that you're trying to target? These are things we need to know better. And then the formats, what's best? One-on-one, that takes more resources than group. Sometimes it's easier to do. Sometimes all you can do when you do when you're doing outreach. But it varies. Do you have to do it in person? Can it be on the phone? What about using social media? Would that be a more expeditious way to do this? Would it work just as well, or do you need the personal touch? Again, these are things that we have to know and research better. Supervising peers, as I said, is very important. The most important thing is you do it. You do it consistently, you do it a lot, and you expect that peers are going to need a lot of support. I like to do peer, because I love peer support, I like to do peer supervision, so that everybody comes together and they learn from each other as supervisors. As peers being supervised. Again, more resources that we'll list in the slides. Compensation's a big issue. Do you pay people? I think you should. A lot of our human subjects boards say that people who have fewer resources find it more coercive the more you pay them. I think that's an excuse not to give poorer people as much as you give people with more resources. I think they deserve to be paid and compensated and shouldn't expect always to work for free. Whether you pay them a salary or you pay them an incentive or an honorarium is up to the local customs, but it's something that really should be looked at. And I don't think of peers as just free workers that are available. I'm getting the nod to finish up a little quickly, so I'll just do some of the retention issues is the last thing I wanted to mention, and then I'll wrap up. I wanted to acknowledge all my co-investigators, the consultants. It takes a village to do a research project, all the staff and undergraduates, the participants particularly. A nod to my lab at the University of Washington with my graduate students and undergraduates there, especially to the Ontario HIV Treatment Network. Thank you very much for the generous conference and inviting me and for all the important work that you do. And I'll stop there. I'll leave my contact information.
Thank you so much. And this is one of those things that for those of us who are starting or doing research seems very simple, almost simplistic, but once you're working with peers, you discover there's a great deal of complexity in working with peers in all kinds of matters. So you have in your program on this page where the panel is the names of the speakers from whom I will ask some reactions. They'll raise some of the topics, they'll delve a little bit further into some others, and they'll tell us their own names, and you can find their affiliations. They're all good friends, and we're really thankful for you being here. So I understand that for some reason the microphones I have to start in an order, but is that the case, or I can start wherever I want? wherever you want to. That's the way we like to do it. So who wants to go first and engage in this conversation? And I'll pay attention to all of you and see what kinds of reactions and comments you have out there in the audience. Don't be shy. And you're all mic'd. You're WikiLeaked. Yes.
So I was very interested in some of the places that the speaker went to regarding peer work. And I guess one of the things that I learned very quickly is that there are sometimes physiological things that I can't change about myself, and recognize that peer becomes really important in how you identify which populations you're working with and what work you want to go. It's not enough that I'm just HIV positive, but I have physical characteristics that are going to lend, an easier approach working with some peers as opposed to others. If I'm working, it's not appropriate necessarily that I'm dealing with racialized communities. I'm an old white guy, gay guy of a certain size, and that can be intimidating to some people, even younger gay men. So I'm really conscious that in accepting a peer position, that I'm really clear on what the population or stakeholder group is.
All right. Tara, I see you nodding.
With what Mike says, I think it's important to, to be aware of that yourself as a peer, of who you can work with easier than other groups. So,
Does that mean that people of other colors and sizes cannot do research? So, Dr. Simoni, is there any research on that?
Is this on? There is some research that's not surprising about similarity. Mm-hmm. The more similar to people, the more helpful that can be. But I don't think, when we used to ask actually the people that were in the study, do you have a preference for the peer that you want to work with? And interestingly, almost none of them would voice a preference. I didn't know if it was in this United States kind of a politically correct, sanitized environment. They were afraid to say, well, actually, I want another woman of color to work with. I would feel more comfortable. But so they wouldn't always say that. But we found actually in practice it did help to kind of match people up as much as we could demographically. Mm-hmm. There's something, if what's powerful about peer support is that you're seeing someone who's kind of like you in the same situation, to the extent that you can make that more similar, it was helpful, we found.
Thank you. Any other reactions?
Yeah, on that same note is within my work, it doesn't necessarily, you don't have to always be able to identify with the person or necessarily similarities with the individual that you're supporting, because I do offer peer support to females. And then also is to be able to, for me on my end, is to be able to understand what is the social determinants of health and how these will be able to impact individuals and what are the intersectionalities. And also for me, what's important and critical is to present in a manner which creates an environment that is conducive for engagement. Mm-hmm. And so it's not about who I am or what my experience have been, but whilst that is necessary, but do we have this culture that allows for or enable us to have dialogue and to be, for me, on as a part of that process, is also to be open to learning and to be able to embrace that. And so what I've realized, with my work is, sometimes I personally am challenged with some of the feedback or the information I'm getting from my peer that I'm working with. And so as I'll be able to support an individual around a particular issue, sometimes I walk away from that engagement, challenging myself or saying to myself, why have I not thought of that for my personal life? And so when the research spoke about the issues around the impact, how has this work impacted you as the lead in this peer engagement, is something that I can identify with and have a great appreciation for, because there is significant impact on the lead oftentimes. And it's great that the research brings that to the fore, because oftentimes it's as we do this work, and the peer leader is left to deal with the emotional trauma, deal and absorb. We have absorbed all of this and provide great service. But then, where do we go and debrief? Who is there to provide the psychological support and emotional support and balance that I am going to need so that there is not burnout or peers don't walk away because they're frustrated and have to deal with the gamut of the issues that are presented.
All right. Okay, so similarities, differences, self-care, impact, there's a lot coming up. I don't want to skip you on that side, Duncan, Sean. Go ahead.
There's a lot, Jane, that resonated. One of the things that I'd like to highlight is Duncan McLaughlin, Manager of Community Health Programs at ACT. The experience of people doing peer work, I'm thinking primarily of volunteers, but also staff, who will talk about the difference that they feel they're making in other people's lives and how that impacts them in a positive way. And so I think that in terms of the benefits of doing peer work, perhaps outweigh the hard evidence that we have so far to demonstrate the usefulness of peer work. That there are a number of benefits that happen for obviously for the people we're working with, but also for the peer workers themselves. And I think that's very clear in terms of what I've heard from volunteers over the years at ACT and from my own experience, both as a volunteer worker and as a supervisor of other peer volunteers. So I think that's very, very important.
Okay, thanks. Sean, while you do that, I'll remind you, if you step up to the microphone, I promise to look that way and acknowledge you. So if you have questions. Sean?
I'd just like to add, it's a real challenge, I know for myself personally, to know when to turn it off, when I guess you're no longer providing the services as a peer. If you're of the community, you live in the community, and you're always faced with the issues your community face with on a daily basis, it's not like a lot of people who can drive home to the suburbs and go to their families and turn that off. So I think the self-care point that you pointed out is extremely important. And as the doctor mentioned, we don't have a master's degree in social work or anything like that. So I think providing supports for people who provide supports is essential.
Right. And maybe even if you do, it's hard to turn it off. So, Dr. Simoni, any research on how people are able to turn it off as we're describing it, and involved in self-care?
One thing I think is important is, and we ask for our peer participants, is having a certain period of time that they can work on the project. And it might be 6 months, which to us in a 5-year study doesn't feel very long. We would like to have peers longer because we feel like we're continually training new cohorts, but realistically in the lives of our participants, that's a long time. Many of them don't know where they're going to be living in 6 months, if they'll be in a relationship or not. There's a lot of transition in a lot of the lives of the peers that we're working with, so we ask for a concrete time period. Can you make at least a 6-month commitment to the project? And then at that time, especially if they're doing well, you have to prevent yourself from begging them to stay on. But to say, okay, you served your 6 months, that's great. If you'd like to stay on and feel like you can do it, that's wonderful. But if not, that was a good time for you. And the hardest thing is trying to get people before they have the burnout. So it's clear when they stop coming and haven't been available or responsive to their peers, but to try to get them before that period, that's what I found was difficult. I mean, we did have some peers that ended, some relapsed, some again after we lost that peer person never came back. And I really missed being able to have that transition, that time to talk about that. So I think one thing to do is have a concrete period of time, a finite period of time that they're going to interact, and anticipate from the very beginning that it's a pleasure, it's fun, there are advantages, but there are also burdens to being a care provider, and to recognize that.
Okay. You mean the researcher becomes a care provider?
No, the peer does. The researcher does too, but the peer specifically.
Okay, so I'll come back to you. I know some of you have not said a word, but I noticed there's somebody there, and so we'll go there and we'll come back here. Is that okay?
Great, thank you. My name is Barb Panter. I work at Katie. And Dr. Simoni, thank you so much for your talk. I agree with so much of what you said, and it's so heartening to see that there's some research out there that supports what I've always believed in, which is peers can have such a huge impact. I did notice, though, that you talked about peers being in recovery, and I would just want to put out there that people who are no longer using drugs are peers of other people no longer using drugs. And the peers of people who are using drugs are people who are using drugs. So I think it's possible to work with people who are using drugs. I think it's possible for them to work. And I think it's really important to acknowledge that they can do fabulous work, because if we don't, we just compound the stigma that those people already are laboring under. But thank you very much for your talk.
Thank you. So some reactions from you, Jane, and from others?
I guess we were just talking earlier about exactly what you mentioned, is when does a peer stop being a peer and kind of move into, I guess, a person with lived experience. There's people, who are professionals in this room right now who've had various parts of their lives doing different types of things when they were peers, but, eventually they've moved on to other things. And I just find it really kind of confusing, that definition, I guess, sometimes.
Okay. Yes.
In terms of the harm reduction, thank you. It's great that you agreed with some of what I said, and even more fun if people bring up comments where they disagree. I hope I said something at least a little bit controversial that some people can disagree. Remember, I'm from New York. It's personally absolutely fine to disagree with me and engage in a debate. And I can say, actually, when we started the peer program, my idea was a complete harm reduction. I wanted anybody to be involved, whether they were using or not. It was the particular group of peers that I had in the Bronx that told me that definitely would not work, and I couldn't do that. And I had actually tried, even before I was engaged in the peers, I had hired people to actually do some of the assessment component, the evaluation piece. So I had some people who are currently using. And the issue was around the petty cash, that I had to have money to pay them to give them so that they could give to the participants when they did the interviews. But the folks that were actively using had a difficult time just not spending that money. And in the end, it got to be that I felt like I was contributing to something that was not healthy for them by giving them cash. It was $100 or $200 because I had to go out and do several interviews, and they would just use it for drugs. So I'm not saying every user does that. No user can have any cash on them. But several of the people we worked with basically never did. Any money that they used, they basically went to drugs. I tried to set up an ATM program or something, and it couldn't work. It didn't work, it didn't work with these particular individuals that I was working with. Maybe I didn't do the right things. Maybe I didn't know how to do it correctly. So that would be kind of an interesting conversation to have. But I'll say I started with that intent. The peers themselves told me it wouldn't work. They said it wasn't good for the people who were still using because they were working with other users. So I'd love to hear more people talk about it. Maybe there's ways I could do a harm reduction approach better, and maybe that's what I just needed to do.
Yeah, the issue of remuneration is constant and it brings up a lot of different kinds of opinions and emotions. I know there's somebody there, and I'll get back to you in a second, but I don't want to pass over Percy, Tara, Hawa.
Okay. For me, when you talk about peer, like I said, I came in at AIDS Community of Ottawa, 1999. I have to mention that first. In 2009, I've been hired to do a support worker. And over 10 years, I was telling, some people don't hear, they have to hear. When an organization is like it's like a grocery. When you go, you want to see your client, you ask them for feedback. If I'm doing good or something is not right, can I change it? It's the same thing. You have to listen when people are talking. As a peer participant, when I tell that doesn't work, it doesn't work because I know what I'm saying because I'm talking with my peers. And we have been saying that for decades that peer is the key of everything, from the up and down. We have to involve peers. When I'm saying that's people living with HIV, because we're talking about HIV. And this is really critical. Myself, like maybe 7 years ago, I wouldn't be here talking to you guys. I can't even see you and look at you on your eyes. But going through leadership program make me, I said, okay, I'm not going to sit anymore. I have to go and do something about that. And often listening that, oh, you're going to burn out, like Charity said, I'm nurturing myself by giving help. This is the way. When after some time, when I feel that, okay, this is enough, I have to step back, I just took 4 weeks and go to Africa, enjoy myself, and come back. And when someone coming to see me as a worker, the first thing that I do, I present myself as HIV positive. That's literally that person said, oh, finally I find someone that will understand me. And it's break everything down and put us more closer to, it's like who can understand, who can put my shoes? It's my shoes. Then we are going the same problem. We understand each other very well. I was saying in the beginning, when someone has a descent from you, like through the testing and got the result, please call Community of Ottawa. I will be there to support them from day one because it will make a difference in their life. And I hope that good people in the room will understand that the peer work is, of course, we don't have. So believe me, I went to Ottawa U to take a degree, a certificate on the activism, social change. And after 3 months, I said, really, I didn't learn anything because I already know what they tried to cheat me. Then what is the, I already know. Of course, I don't have that paper saying that you have that degree, but what I have, we cannot have in university. Thank you.
Thank you. So hold on a little bit. We have a lineup, which is a wonderful thing to have. So I'll get back to you guys. Okay, so I think you were first, and then we'll go one and back and forth. Go for it. Tell us who you are.
Hi, I'm Tracy Conway. I live in Sault Ste. Marie, and I'm on the OHTN Governance Committee. So I had a couple of kind of tied together questions. You have quite a diverse group of individuals up at the front, but they're all peers. So maybe any challenges you found when coming up with that definition or key commonalities that peers would share. And then in terms of support for peers that are doing work, maybe any challenges or ways to address individuals that might be more isolated and hard to reach that are doing peer work, like maybe geographically or like not able to get out and about, and how maybe you would address some of those concerns?
Right, thank you. So challenges with a definition, and so maybe Percy, Tara, this is your chance. Dr. Simoni says she's open for challenge.
I think check 1, 2, 3. Good morning. Good morning. Good morning. Good morning. There we go. Can you hear me at the back of the room? Perfect. So I think with some of the challenges, I just want to talk about some of the things that I think that have been taken from Indigenous frameworks, because I work at an Indigenous agency that provides supports to Two-Spirit and trans folks, is the reciprocal nature of peer work. In the sense that some of our tenets, despite colonization, some of our foundational tenets is that if we give, we receive, right? There's something in us giving to others in our own community to help creating a culture of healing that assists in our overall wellness, our holistic overall wellness. And also just want to talk about, one of the things that I think people are starting to learn about is having multiple relationships. In a sense that our multiple identities, not only am I a peer, not only am I Indigenous, not only am I someone who lives with a particular infection, but I'm also part of the community, right, where this research is happening. And I think one of the ways in which my particular agency has worked through what it means to engage with research is having the OCAP principles as a part of our work, right, ownership, control, and whatnot, to have a sense of involvement, because I think there has been an experience of Indigenous folks being researched to death, literally. and not having any involvement, not having any say, not having any self-determination within the research process, that we are for us by us, right? Because not only do we have peers, but we also have peers who are now becoming academics, right? Getting their alphabet soup behind their name, right? So that's my perspective.
That's wonderful.
Thanks.
Thank you. Tara, can you hold on for a second? We go back and forth. Is that good? So, Robert, I think.
Okay, thank you, Dr. Simoni. You mentioned the difficulty of showing efficacy in targeted outcomes, and especially in prevention. One of the outcomes we're most interested in is really reduction of incidence, which requires a huge trial that nobody has the money for. Except just last week or a couple of weeks ago, there was this provocative result from the Centers for Disease Control that, for example, counseling in certain settings did not really show efficacy in a rapid testing situation to be able to reduce incidence of STIs. So I'm just kind of wondering, where does that leave us in terms of the variety of different ways of either providing counseling, peer support, interactions, in terms of our ability to actually either find that kind of a hard outcome which is desirable, or does it mean we're looking for other kinds of outcomes, which I think this panel has been very articulate in expressing about thinking about the way in which people's lives are improved in other ways which are quite important. I hope I asked the question properly, but it doesn't seem like incidence reduction is achievable at the moment through the variety of means we have.
Thank you.
Well, that was the question I asked you all, and I was hoping you were going to tell me. But good point. I mean, in terms of the targeted outcomes, I didn't even mention incidence. It wasn't even in there in any of the studies, right? It has been done. NIAID and NIH does have the money to do those trials. They cost, close to $50 to $100 million to actually do them with 10, 15,000 people in them. And the only studies that have shown incidence outcomes are often the biomedical ones, right? The PrEP, the treatment as prevention in serodiscordant couples. So they have been able to show them as outcomes then. I think there's a lot of things I could say about it. One is, I'm hoping we can have a discussion of the different kinds of outcomes we need to look at that are still important, even though they're not incidence outcomes or viral load or CD4. And second, maybe the issue is that when you do, there are limitations to our research methods, right? And we do a randomized controlled trial. We don't ask everyone in the study what they want and give them what they want. We say, we're in a study, here's $20. We're going to flip a coin, and we're going to put you in intervention A or intervention B. And at the end of it, we're going to see if you're better. And we're hoping that because B is the peer intervention and A is the one where you got kind of standard care, that you're going to look, the ones in B are going to do better. But we know that's really not how it works in the community. You don't force someone to have peer support if they don't want to have it. And I think maybe the key is in the moderators. The moderators are, for whom does this intervention work? And maybe if we did our research more like we actually did our practice, we would be able to find better results. So that we target people who really want support. We ask them the kinds of support they need and want, and we provide that for them, and we do that in a more rigorous fashion. I think we can show better results. And I learned this from my own research. And if you recall the slide about, well, how much of the intervention do people actually get? Very few people came to all 6 sessions. It was hard. I actually wanted to do weekly sessions. But the feedback I got from the peers is, hey, having HIV is kind of a full-time job, especially when I was doing this a few years ago. I got appointments to go to, I got to keep up with my meds and my refills, and I'm at a bunch of different events and activities. It's actually hard to get to a group every single week. So we did kind of tailor it to them. But still, it was hard for people to do that. It was hard for them to take advantage of the full intervention as we laid it out. So maybe that's the answer in terms of doing better research, having it, we talk about empirically supported practice, right? Research supported practice. I have a colleague, Reve Amico, talks about we also need really practiced informed research. We need research that better reflects what we're actually doing in the field. And I think that might be the way that we can show with our research what we're feeling that we're doing in our practice.
Okay. Thanks. So I'll give the floor to Tara if you're ready to say a couple of things to us, maybe react to some of that. Then Gareth has expressed some interest. Then we'll go to the floor. Then we'll go to you, Duncan.
Okay. Am I on? Yeah. Okay, so I wanted to agree with Hawa completely that if it wasn't for peer support, I wouldn't be here either. So it was, and I didn't really understand that word peer either. I was, pregnant with HIV, and there's other pregnant people with HIV, and we could sit in a room and talk about that. That's what I needed at the time. I needed to know what they were going through, what it was like on so many levels. And then it was the leadership course, where it was this first time I sat in a room with leadership, people who are leaders, who are living with HIV and being leaders. And we were all living with HIV in that group. And that's where I had my aha moment of what a peer was to me, or what my definition of peer work is. Our groups meet not daily or not weekly. We meet, 7 times a year, and it's for 3.5 days or 2.5 days, where we talk about what we can do and can't do, and what's hard and what's not hard, and how we can help others and help each other. And I really related with the helper therapy, because that's why I got into this work as well. So when it comes to a definition of peer, I think HIV is really important, but it's those other factors too. And so in the work I do, it's all about leadership and what we can do as people living with HIV in leadership roles, whether it's governance, helping other peers, research, whatever else we can do. So that's my little spiel.
Thanks so much. So Gareth, briefly, and then we'll go on.
So in relation to the question asked a while ago by the gentleman and the doctor's response, is I think part of what is missing is attention that is given to helping our peers to have options in around changing behaviors and attitudes. And so I don't think much, even from a research perspective, is as we engage with peers, is that much time and effort is not put into creating that environment or that culture that a peer will walk away having options in deciding, what they do. And so I think in terms of looking on results or what could possibly be done differently is integrating this the physical kind of environment and creating that kind of a change and bringing persons in a space or environment or a culture that will enable change in behaviors and attitudes. And I think if that becomes a part of that formula, we will likely see a more positive results or some of the results that we might not be seeing just now. Because we have to also understand that, again, from a research perspective, is that we see some of the individuals as subjects. And even literally in that sense of that label and how they're being seen, it determines the level of kind of intimacy or the kind of interaction that happens, whilst we are focused on the outcome, what we want to achieve, but not realizing that the balance of what we could get is how do we facilitate, how do we enable, how do we push persons, how do we support persons or encourage persons towards this greater good, which will give us this targeted outcome.
Thanks. Yes, sir. I think, yes.
So my name's Joel, and I'm a nurse working out of Sudbury, mostly working with a pilot project trying to improve access to HIV treatment among very highly marginalized populations. I'm very happy to see the research that I did see here today. Certainly supports what I've seen in Sudbury. The population that I work with is mostly injection drug users, homeless, some of them for decades at a time. And not really much education. And this project was rather small, so we really didn't have much time to do much formal peer involvement. But what I really was amazed was how much of this I actually did see within the population. Just through the education that I was able to provide with the few clients that I did serve, really how much of that knowledge transfer did end up in the streets. I'd be out on outreach and I would honestly bump into a client and he'd be talking about CD4s and drug resistance and the importance of staying on medication. And meanwhile, many of these clients, most of them don't even have a grade 6 level education, and they're talking about very complex issues and actually making it click with a lot of people better than even I could, just simply because they can explain it much better to people they're associated with better than I am. one thing I really find is that it's hard to give recognition to these people who are kind of doing the informal peer work, particularly because I have witnessed among this population, particularly the few that I have been serving, just such a shift in the culture and knowledge of HIV and risk factors and harm reduction practices among this population. And even to this day, like I'll be out on outreach and I'll have a client drag somebody to me and tell them, you need to talk to this guy. So it really does present like an opportunity for testing and stuff like that. And I really do think that it should be something more recognized by professionals.
Right, thanks. So any comments? We have remuneration, recognition, self-care, all those things are floating in the room. And Duncan, I know you have other things to say, but also if we can continue the thread as well.
There is so much to say. I actually did want to come back to the question about incidents and Jane's comments earlier about how do we, how can we connect with people before they become infected? And that's a huge challenge, but I think it's a shift that's happening in the ASO sector more and more. And at ACT, we've been fortunate to have a program called Totally Outright for the last 3 years, which originated from the Community-Based Research Center in Vancouver in 2005. And this program is designed specifically for young gay men and to help them and support them to become sexual health leaders. So people take part in an extensive leadership program, and they develop networks and they develop ways of accessing knowledge and accessing healthcare. So they're primed in a sense to have support and to be connected should they become HIV positive. There's amazing things that happen in terms of the evaluations that we do and the changes that happen in these guys' lives. What we don't have is any resource or ability to follow them longitudinally to see what would happen in 3 years or 5 years or 10 years. And so I think there's a challenge there around, there is programming that's happening right across the country that creates an environment where we might be able to look at, does this kind of programming have an impact on incidents down the line? But there is currently no research that is looking at that I'm aware of in terms of being able to follow this population.
Hello? Ah, there you go. I thought they cut me off. That was it. So thank you. So there are a number of models that have been developed, well, in the United States and in Canada, and we're very proud of them. They're working really well, and it's very provocative that you say, people who might become HIV positive and to start intervening even before. So I'll be remiss if I don't plug our own program at the Ontario HIV Treatment Network. Mr. James Watson is there, and we've worked a lot in the learning exchange for HIV and AIDS peer researchers called LEAP, and it's online. There you go. I had to do it. And Mr. Lee, I see you there.
Are you ready for me?
Bring it on.
Okay. So, I'm Alan Lee. I'm a primary care physician at Richmond Park Health Center, and I work with the Committee for Accessible AIDS Treatment, which focuses on improving treatment access as well as facilitating leadership building amongst immigrant refugees and racialized PHAs. And I wanted to raise 3 issues. One is about, I really want to follow up on your last point about practice-informed research. Actually, I think it is a more rigorous way of really evaluating real-life situation, which I think especially applicable to the peer situation, because peers is not really just an intervention group. They are a community, right? So there's a lot of life changes, dynamics that happens that are beyond, a very positivist kind of framework of measuring very specific variables. So I think in order to really demonstrate the benefits that we all experience from the front line, I think maybe some of the factors we can consider in terms of measuring is one is about how do we measure the stabilization of other life challenges and social determinants before we try to measure these so-called end outcomes much further down the treatment cascade, right? So I think that's also echo what some of the panelists are talking about. A lot of the frontline experiences are really about stabilizing, improving other people's lives. And the second thing is, I think, is about the relationship is not really about how we train the peers, but how we learn with the peers and how the peers are integrated fully into the service delivery system. A lot of times we are still seeing, and that goes into the whole framework of not looking at people as just an intervention group, but really looking as a community. As a community, we don't really just compartmentalize people into you go to this 6-week program and then you're done, right? Because people come and go and then life happens, but then, people come back. So I think that's also important, following that practice-informed research framework that you talked about. And I think the last point I want to make is about, you clearly demonstrate the benefits shown in the helpers, right? And I think the bigger question is, how as researchers, policy makers and funders, do we support progressive engagement of peers? We're not even talking about, when we're still talking about honorarium or not for peers, how are we truly recognizing the contribution of people, right? So I think if we can demonstrate clearly that the benefits is shown in people who are taking on a helper role, I think the effort really should be focusing on how do we maximize the meaningful participation of people with lived experience so that they can maximize the benefits. Thank you.
So he's touched a nerve, evidently. I don't think people are just applauding because, it's early in the morning. So Alan has mentioned 3 significant points, and so who wants to, Jane, you want to give it a first go? Or?
I'll say one thing. That was great. That was beautiful. It shows really your commitment and how closely you're working with the peers. Thank you. One of my colleagues did a study because she realized how powerful it was to actually be a peer, to actually be the therapist providing the care. It's empowering, according to the helper therapy principle. It's actually beneficial. So she wanted to do a study in which all the targeted groups actually became the peers, the ones who did the work. So she divided youth up, and instead of training people to go out and provide care to them, she brought the youth in and trained them all to be peer providers. She put them all through the training so they could go out in their community and be advocates for safer sex. And I think that's an example of a kind of research project that will reflect more what's actually happening in practice. And I think we do need kind of novel programs like that to try to do it. But
anybody else wants to? Mike, please.
I think some of this really speaks to the coin that we all value. And for myself, I know that I don't necessarily do the work, or even the role I play in community really isn't about receiving financial remuneration, although that's very important. But really what happens is my curiosity gets fed, and I've still managed to maintain, not just as a community member, but as a person with HIV, a gay white male, certain age, all those things. I still have a curiosity about other people. And I recognize that some of that comes from losing my peer group and needing to be able to re-engage as I move along in my life, and how do I do that? And for me, getting my curiosity fed, learning new things, experiencing opportunities to meet with other groups and just see how people do it is really the coin that keeps me involved in not only the work, but Dr. Trevor Hart's stuff and motivational interviewing, Rick, some of the rollouts that actually happen in our community, and the capacity that everybody builds to be able to go back into their community and become unintentional resources, I think still benefits the community that's being studied.
unintentional resources. I'm sure that will stay with us. We're not going to end yet. We have a few more minutes. Thank you, Mike. Very important that I think you're all inspired, and it's important that you know that we invited all these wonderful people not only to sit in the vinyl couches. Are the vinyl real there?
Bonded.
But that you should feel, and I hope I'm not speaking out of turn, that you should feel free to talk with them, come up to them and say, what was that model you mentioned, or what was this or that? Just talk with them. They are our friends, and you're our friends, and so do a lot of that because the time is always, limited. So we're going to entertain one more question, lucky you. And sorry about us, and then we'll have maybe some parting thoughts.
Hi, I'm Lynn Chapa, and I'm an OHTN peer researcher. And I want to kind of shift the lens on this conversation a little bit. I agree with everything that's been said. As a peer researcher, I've experienced all of the benefits that have come to me, and I've got more skills, and I've got more support, and I'm like a better person, and all of this. But in many, many ways, this conversation feels a little paternalistic, okay? We're talking about the benefits to the intervention group, okay? And Dr. Lee, if I didn't love you before, I love you now, okay? The fact that we're even talking about remuneration and whether or not peers should be paid is insanity, okay? Any of the professionals, the academic researchers in this room, is there ever a question that you're going to be paid? Is there ever a question? Okay? I am doing the work. After that. Doing peer research does a lot for me, but what's almost never discussed is what I do for the research. The reason why I do my work is because the information that I give you as a primary investigator is more ethical, it's more accurate, it's more rich in detail, okay? I've built a community or helped build a community and made them feel empowered because I've told them that their life experience is valuable, okay? I have contributed to this research as much as anybody else. And when you say, should a peer researcher be paid? In our society, value is measured by money. That's it, that's all there is to it. And when you say, oh, should we pay our peer researchers $50 per interview? Or should we just let them do it out of the generosity of their hearts? It's like, I'm not just a patient. I am contributing to this study. And I think I want that to be recognized a little more. Like Michael said, really the money is not such a huge thing, although it's nice, but money recognizes value.
Okay. Okay.
Thank you.
Thank you. So we're going to end on a vigorous note. So whatever parting remarks you have, wrap that up with your parting remarks. How about that for a challenge? And because then we have to, make room for other people. Okay. I think Iowa.
Hawa.
Hawa.
Hawa. Hawa.
And your microphone is working, Hawa. Yeah.
Yes, I reinforce what Lynn said. I remember again when I came to Education of Ottawa, we are 3 Black women, and today, if I'm not mistaken, we have active member of ACB community, 171 kids because of the peer. The peer work is priceless. And we're not going to continue to work as a volunteer. Like she said, we need to get paid, and that's it. People need to work. And now on, we know that with the treatment, people are living longer, they're going back to school, they want to work. Then I'm having in our group what we can do I want to work, you know. If we are train them being peer educator and pay them, well, everyone gonna benefit from that. And the study, we don't need a study to show that the peer work. I am here, he's here, he's here, he's here, everybody's here. It's a life experience, we are live. This is working. You know?
Thank you.
Yes, thank you. And the one thing that I want to add, the challenge that I have really is about accessing treatment. Mm-hmm. You know, when in Canada, 2013, there is a people that have to have a problem to pay medication, HIV medication. That is ridiculous, you know. We have to make it sure that everyone that wants to be on treatment have a medication. This is no way that we can left anyone out. Yeah. That's what I want to share because it's ridiculous. Thank you.
Duncan, and then we'll go kind of up fast. This is fun.
First of all, I've benefited enormously, and I'm very grateful for all of the ways in which my lived experience has been supported and affirmed back to me, and I think that's a very important thing for any peer to get. Second, I'd like to say that particularly as we think about new research dollars going towards bringing back to the treatment cascade and potential interventions around peer navigators and other folks that might be part of interventions, a real strong plea and call to recognize and remember this conversation that we're having this morning about the value of peers, because one of the things that I know as a program manager is that we get a certain amount of funding, and if we're able to make the case for peers attached to that, then we are provided an honorarium. And what I have to do is figure out, okay, how do I take those dollars and the responsibilities of that role, and how do I pay that person a decent wage as if they're part of our unionized staff? And that's an enormous challenge. It's one that I welcome. It requires a great deal of creativity, but that's about valuing peers.
Thank you. Sean, some parting words. 2 television minutes.
I would just like to give that lady a big hug in the back there for her comments earlier. My life has been greatly improved by the peer work I've been able to do, but it still really amazes me, people, professionals, what they ask of me sometimes and expect it to be done for free when they're always doing everything, on salary, including this conference, So I hope this is a learning situation for everybody, and that next year things will be better from a peer perspective.
Okay. Proceed really quickly as I see those people.
Yeah, I agree with what Mr. Lee had said and the comments of the woman who brought up the real conversations that need to be happening. We shouldn't be sugarcoating or putting a nice, lovely icing on top of this cake. I think they're very critical perspectives, and I think there's, again, a lot that can be valued. I don't think you need to have a master's to be a peer. Actually, your role is changing, because I as someone who has education, I know my role changes, so I step back and create space for other folks to engage with different members of my community.
Thank you. Tara?
Yeah, thank you, Lynn, for saying that. Also, Dr. Lee, the word community, that needed to have been said, so thank you for using that. I think that's what it is. It's a community, and we're creating a community. I know that personally, what I have learned and the amount of knowledge that I gained from working with my peers is amazing. And once again, I've been to school, and I could never have learned that in university at all. So this work benefits me, but I know it also benefits others, so thank you.
Okay. Jane, actually, I'm going to do the worst possible thing. I'm going to stop at you with my apologies to the three of you, and thank you for being with us here, and your final words.
I think we had great final words from the panelists and from the audience members who are really most committed to the community, so I'd like to leave with those as the parting words.
Thank you, and thanks to all of you for real. Please talk to the rest of you as a person with HIV. I tremendously thank you, and thanks all of you. I hope you had fun and you learned something, and you please talk to these wonderful people. Thank you.